All right, I'm Dr. Holder. I'm a pediatric epileptologist. I currently work at Guerin Children's, which is part of the Cedar-Sinai hospital system. I've been in California about 10, 12 years. I've been at this hospital about 2 years. I've been using vagus nerve stimulation therapy for a very long time. I'm older than I look, probably since the late 90s. It's been used in pediatrics for about that time. We did some compassion use trials when it was being studied in children. So we have actually quite a lot of experience. I have about 1,000 kids that I've prescribed VNS therapy for, so we have quite a bit of experience. I'm going to say kids, I'm a pediatrician at heart, but some of my kids are in their late 20s. So even though I'm going to use the word kids because that's kind of where my brain lives, we have patients of all ages, so from very young children up to some young adults. So everything that we're going to talk about will apply to the entire age range. So we'll talk a little bit about VNS, and then we'll leave some room for questions as well. So if you have any questions, we can answer them. All right. So we're going to talk a little bit about drug-resistant epilepsy, about how we use medications to treat seizures, other treatments that we have when medications don't work, and then we'll have some questions at the end. So what is drug-resistant epilepsy? So it's interesting when we think about epilepsy in general. As an epileptologist, which is what I am, which is a doctor who specializes in the treatment of epilepsy, when we train in the world of neurology, for pediatric doctors, we do pediatric training first, adult doctors do adult training, and then we do neurology training, and then we do child neurology training, and then after all that's done, we do special training in epilepsy, either 1 or 2 years. So for me, I did 7 years of training to be an epileptologist. So there's a lot of training that we do to be able to specialize in taking care of people with epilepsy. And we know that when we're treating people with epilepsy, about 1/3 of our patients will not respond to medication. And the interesting thing about that number is when you think about all the medications we have available to us now versus when I started in this field back in the late 90s, we've had a lot of new medications come to market. So you see there's a lot of companies out in the expo, and if you just Google anti-seizure medications, you'll see quite a long list. You would think that when you compare to the medications we had maybe in the 70s or 80s, where you could count on one hand how many anti-seizure medications we had, and then you look at how many medications we have now in 2025, you say, well, we must be better, right? We must be better at treating kids with epilepsy or adults with epilepsy. We must be able to get more patients seizure-free or more patients seizure-controlled than we could back in the 70s. But when you look at the data, that's actually not true. The number of patients who fail to achieve seizure control on medications now is exactly the same as it was back in the 70s. And what we find is that if a patient comes into my office with new onset seizures and I prescribe them a seizure medication that should work based on the seizure type they have, we get about 50% controlled with the first medication, assuming you're matching the medication to their seizure type. After they fail the first medication, we start a second medication. You get about another 15% seizure controlled with the second medication. After that, we really run into trouble. With the third medication, we only get about 4% seizure controlled with that third medication. And what that leaves us with is about 35% who are drug resistant and just don't respond to medications. And the interesting thing about that number is when we repeat that study over and over again, it was done in the 70s, it was done in the 90s, it was done again in the mid-2020s, we still find that same number. It ranges between 34 to 36%, so we're really no better with our new medications. So what's the benefit of these new medications? They're better tolerated. So you could argue that someone's going to feel better taking lacosamide than they did taking phenobarbital, which is a medicine that just kind of puts your brain to sleep. So patients feel better. They don't have as many side effects. We don't have to check as many lab tests. But from an efficacy standpoint, we're really no better in getting patients seizure controlled with most of our new medications. There may be 1 or 2 that have come out recently that may go against that, but other than that, really we struggle getting patients seizure controlled on medication in this what we call drug-resistant epilepsy. So what do we do with those patients? Do we just say, well, sorry, we're done, just go have seizures? Well, of course not. We want to offer them other options. So the other options we have really 4 ways we treat seizures. We have medications, which is what we always try first. We have surgery, which is probably the best option if you're a candidate. And then we have a broad category that we call neuromodulation, and we have diet therapy. So within the broad category of neuromodulation, we have a couple of devices that are now available, and vagus nerve stimulation is one of those devices. So that's really what we have available to us now in 2025, which is way more than we had 10 years ago or 15 years ago. And with those options, we can make a lot of impact on getting patients seizure control and getting better quality of life. So what does this number account for? It's about 3.4 million people have active epilepsy, and about 35% of those are drug resistant. So it's a pretty big number. When we think about who has epilepsy in this country, it's 1 in 26. That's where this number comes from. It's about 65 million people worldwide. So if you take 35% of that number, it's a lot of patients, right? There's a lot of people out there. It's really our second biggest group, if you think about it. So 50% get controlled with the first medication, and 34% are drug resistant. So it's really the next biggest group of patients we manage. It's almost 100% of my patient population, because that's what we kind of specialize in as epileptologists, this group of drug-resistant patients. So when we see patients with drug-resistant epilepsy, obviously in the back of my mind, I'd like every patient I see to be seizure-free and have no side effects. Obviously, the drug-resistant population is a little more challenging. So we do want to gain seizure control. We want to reduce side effects, but I think more importantly, we want to have the best quality of life. So we want to try to find the best seizure control we can with the fewest side effects, doing what we can to get to that goal. That may be medications, that may be surgery, that may be neuromodulation. So what's the problem if we don't treat seizures? What if we don't keep trying? Well, that's really a dangerous place to be, right? We not only have adverse effects of long-term seizure medications, we have an increased risk of bad things happening. So we have not only the risk of having long seizures, uncontrolled seizures, having injury while you're having seizures, we have the risk of what we call a sudden unexpected death in epilepsy, which is a risk for anybody with epilepsy, but an increased risk the more seizures you have, especially the more convulsive or generalized tonic-clonic seizures you have, and an increased risk if you have those seizures while you're sleeping. So this is something we always have in the back of our mind as we're treating patients who have uncontrolled seizures. And then we have a whole bunch of diseases that travel along with epilepsy. The medical word for this is comorbidities, but it's just seizures that travel with epilepsy. In children, we see a lot of learning problems. We see attention deficit disorder, attention deficit hyperactivity disorder. We see a lot of depression and anxiety, which is a little harder to screen for in our children, but it's definitely there, and we see it, especially anxiety. We have a high risk of anxiety in our kiddos with epilepsy, and on the adult side, there's a very significant increased risk of depression and anxiety in our teenagers and in our young adults. So this is something we need to think about, and we need to manage and treat those symptoms and not forget about them and only focus on the epilepsy. Our kids have a high risk of hospital stays and ER visits. We have injuries related to seizures, and then we have problems with how the brain thinks and learns. Even if your seizures are well controlled, just the fact that you have seizures can make your brain learn differently. So really, in a perfect world, I'd like to think that there's a perfect world out there that we could get everybody with epilepsy treated the way they need treated. It honestly doesn't happen right now. But in my perfect world, everybody with epilepsy would have neuropsych testing. The problem is there's not enough neuropsychologists out there, and insurance doesn't always agree with me that patients need that. So we're working really hard to make that happen. I also think everybody with epilepsy should get genetic testing at their first seizure. We're getting closer to that now, but we're not quite there yet either. And then we have a whole lot of adult patients who never got genetic testing when they were a child, so we have to catch them all up. And that's an even harder kind of barrier to get over. So there's differences in how your brain thinks and learns when you have epilepsy. Even if your seizures are controlled, your brain may still think and learn differently, and that can impact everything, from schooling as a child to how you do your job as an adult. And really, neuropsych testing is the only way to get to the bottom of that. And in this country, school teaches everybody the same. And if we don't look at how your brain thinks and learns, you're not going to get that individualized education plan that you need. So that's really important to think about. And then problems with just socialization and how you interact with your peers and how you live with your epilepsy. So all these things we need to think about when we're treating people with epilepsy. So let's talk a little bit about VNS. So VNS is indicated for patients who have drug-resistant epilepsy. It's used across the age span from age 4 up. It's been used in more than 135,000 patients, including 40,000 children. It's been shown to be effective in treating what we call drug-resistant epilepsy, which now you all know what that means if you didn't already. And the goal of VNS therapy is to do our best to really get better seizure control for our patients. And it's interesting when you talk to patients who have gotten VNS therapy and you ask them about their experiences, a lot of patients, really most patients, wish they had heard about it sooner. I've had patients where we've done VNS therapy and their seizures have gotten significantly better. A lot of my young adults and teenagers, and they're like, well, why didn't we know about this sooner? Why didn't someone say, I mean, we've had seizures for such a long time and we haven't responded to medications. And often, I just told you earlier that we know someone's drug resistant at the 3rd drug. So once they failed 2 drugs, the likelihood a 3rd will work is only 4%. So right there, we know someone's drug resistant, yet most of the patients who come to see me for a second opinion have been on 10 or 12 drugs. Yet we knew they were drug resistant back at the 3rd drug. So we could have intervened right there, which is sometimes 3, 4, 5 years sooner, and done something like VNS therapy. And what would have been different? Maybe they would have had better thinking and learning. Maybe they would have been able to do better in school. Maybe they'd have a different life now. So a lot of families are frustrated that they didn't get this earlier. So I think we have to not only work to educate our providers. So we did a program yesterday, a continuing medical education program, to try to teach doctors to be more aggressive in treating their patients. But we also need to educate patients and families so that you can ask your doctors, what about this? I heard about this. Is this an option for my family member? Because that's the only way we're going to get these therapies into patients faster. So when do you think about VNS therapy? Well, really anybody with drug-resistant epilepsy who's stable enough for a short surgical procedure is a candidate. This can work for any seizure type. It can work in any patient. So there are certain seizure types we know respond a little better or maybe a little faster, but really anybody with epilepsy who's stable enough for the short surgical procedure can be a candidate for a VNS. So if you have a family member with seizures who hasn't responded to medications or hasn't tolerated medications enough to get to a therapeutic dose, then VNS may be a good option for you. So this is something that we want to think about. The other nice thing about vagus nerve therapy is that it's independent. It does what it does without you having to think about it. So if we have trouble with remembering doses or compliance, this may be another good option. Some of the benefits are decreased seizures, shorter seizures, quality of life improvements, being able to decrease or come off medications, no medication side effects. We've seen in large studies looking at how VNS works that patients are in the emergency rooms less often, and when they get admitted to the hospital, they're in the hospital for fewer days. We also see some interesting what we call quality of life improvements. So patients tend to be more alert, they tend to be more interactive, they tend to recover from their seizures much faster, so that postictal period where patients are sleepy for hours, that tends to be much shorter, and the seizures tend to be less severe. We also see, I already mentioned these, so head of my slides. So some of the quality of life improvements in memory and mood. So VNS is also used for depression. So we noticed when we first started doing VNS in patients many years ago, we noticed that kids who got VNS were happier. They just seemed to have a better mood and a better disposition. So it was also trialed in the treatment of depression, and it is efficacious in treating depression. So, medications mostly have negative side effects. VNS tends to have positive side effects. So we see this improvement in depression, this improvement in mood, this improvement in alertness. Kids tend to be more alert, more interactive, and then this significant decrease in postictal period. Instead of sleeping for hours after a seizure, many kids bounce back after 20, 30 minutes. So instead of losing a whole day, we can get back to our activities. So it's approved for ages 4 and older. Again, been used in a lot of patients. VNS is effective in treating drug-resistant epilepsy. And we've also seen improvements in development. Anytime you stop seizures in a child or control seizures better in a child, we have a chance to then have development take off and have improvements. So we see fewer seizures, shorter seizures, less severe seizures, and better recovery.
Prior to VNS therapy, we were really struggling as a family. Bennett's seizures would affect our daily life, our family life. Bennett would have a seizure unexpectedly at the grocery store or when we were at church services, and we really didn't know what to expect in our day-to-day life. It was hard on our family, it was hard on his siblings, and it was really hard physically on Bennett. I'm Lindsay Caroon, and my son Bennett, he's epileptic. We're a military family, so our family deals with larger than normal amounts of stress to begin with. Bennett was 18 months when he started to seize. When he had his first seizure, we thought it was a fluke or maybe a febrile seizure or he was sick. The second seizure, we looked again for some more reasons, and then by the third seizure, we knew Bennett was epileptic. So with the VNS, it was another chance at improvement. This might work. This might give him a little bit better control.
Hey, my name's Bennett. I've had VNS therapy since I was 4.
When Bennett first started experiencing seizures, his seizures increased in both severity and duration. Bennett had one seizure after another, up to 100 seizures a day. We did an overnight EEG, and that's how we determined how many seizures he was actually experiencing. And so we started along a path where we tried different medications and different treatments for Bennett's epilepsy and tried a variety of things, investigated VNS, and there was some time that passed and many, many seizures passed. But after Bennett was implanted with the VNS, gradually we saw his seizures start to improve. Bennett's had VNS for over 5 years now, and so 5 years later, Bennett is not experiencing any seizures currently, and he's been over a year seizure-free. VNS therapy gave me peace of mind because I knew that the device might catch a seizure before I'd ever see it. And that gave me a little bit of safety and security, knowing that I had something else on my side. I didn't have to constantly be on guard against a seizure because the VNS was in his body and it was working. Epileptic children are so resilient. They deal with so much. And Bennett has had a remarkable journey. After implantation, Bennett experienced some vocal side effects. We noticed that Bennett would sometimes cough, or it would sound as if he was speaking into a fan. Over time, Bennett learned to modulate his voice, and now you can't tell when his VNS activates. But right after implantation and after his first surgery, we could hear vocal changes because of the VNS. His life is full of color. We've met some of the most amazing doctors, nurses. Everyone we've interacted with has been wonderful. And it's not the life we planned. It's not the life you plan when you hold a newborn baby in the hospital or when you get married, but it's a beautiful life. It's a rich life. It's a full life. We love it. If someone were considering VNS therapy for their loved one, I'd tell them to do the research, tell them to have honest conversations with their doctor, and I'd tell them that there's a chance it can help. In our case, it's wonderful. It's changed Bennett's life.
All right, we're going to talk about how VNS works. Do you guys have any of the little plastic models you can pass around? They're probably some at your booth. Okay, so VNS is a small device. Oh, I felt like I still heard the video playing. It's implanted under the chest. It's kind of like a pacemaker for the heart. We kind of call it a pacemaker for the brain. So the device is implanted under the soft tissue of the chest, and then the wires wrap around the nerve in the neck. So this is not brain surgery. This is kind of outside the brain. So we access the brain by using this nerve in the neck, which sends a signal. It stimulates this nerve in the neck. It sends a signal to the brain, changes the way the brain works, and seizures get better. Most of the patients that I have, patients across all ages and across all developmental spectrums. Some of the patients who are able to communicate with me and tell me how it feels usually describe it as a tickle in the neck when it's first implanted. I haven't had patients describe it as pain. Some of my patients don't feel it at all. Usually over time, they stop feeling it. Your brain's pretty smart. Oh, sorry. Thought I was doing something wrong. When something turns on and off all day long like the VNS does, your brain kind of stops telling you that you feel it. So occasionally we'll get kind of a frantic call a few months into therapy where the patient's like, oh, I think my VNS is off, I don't feel it anymore. It's not off, it's just the brain not telling you feel it anymore. So the device turns on and off 24/7. A typical example of a setting when it's first put in is it'll fire, turn on for 30 seconds, then turn off for 5 minutes. Does that 24/7. So 30 seconds on, 5 minutes off, 30 seconds on, 5 minutes off. That 30 seconds on is the active period. That's when it's stimulating. That's the only time you get side effects. So during the 5 minutes off, there's no potential side effects. The typical side effects, like you heard from Bennett's family, is there's a branch of this vagus nerve that goes down to the vocal cords. The wires are placed above that, but we get a little downstream effect, and sometimes there are some voice changes. I usually describe it as a little bit of a vibratory quality to the voice, and that does usually get better over time. When we look at our data 1 year out, 2 years out, 3 years out, by 3 years it's almost completely gone. Even by 1 year it's significantly better, about 80% better. Some patients aren't bothered by it. I do have some patients who sing professionally, and they can turn their device off temporarily when they're singing if they feel like it affects their singing voice. That's really the only time that I've had patients really be bothered by it. I do have some kids who get a little bored sometimes in school, and they'll turn their device on with their magnet and hum just for kind of to just, be like, oh, this is kind of fun. So, but it's not a significant problem. You can get some coughing anytime we turn the device up. You can get coughing for maybe 24, 48 hours, but usually, again, not problematic. And those are the biggest problems that we see. Occasionally, you can get a little shortness of breath. I see that most in my athletes, people who are very high-functioning athletes. If they're doing long runs or doing very athletic activities, occasionally they can get shortness of breath. The way that you temporarily deactivate the device is by taping the magnet over it. So the device comes with a handheld magnet that's used both to turn the device on if you want to activate it during a seizure, but you can also use that magnet to temporarily deactivate it by just taping the magnet over the generator. You have to physically tape it over the generator. As soon as you untape it, the device will start running again. So if you're ever in a situation where you feel like it's causing side effects, your patient, your child, your family member is doing something that seems a little odd, they're having coughing or they say it's bothering them, you can tape the magnet over the generator. It'll deactivate it temporarily. If whatever the symptom is goes away, then you reach out to your doctor and say these settings just aren't being tolerated. If it continues, then you know it's not the VNS causing the problem. You just untape it and it goes right back into a off mode and then back into your on mode. So the normal mode, this intermittent 30 seconds on, 5 minutes off, we think of that as preventative therapy. So that's just like giving your child or your family member with epilepsy their seizure medicine. You does it every day, it prevents seizures. Then we have autostim. So autostim I like to think of as preventative therapy, or as a rescue therapy. So we all have our rescue medications that we use when someone has a seizure. So you see a seizure, you give a rescue medication to try to stop or shorten the seizure. This is a built-in rescue medicine, but it doesn't cause any side effects. So this is a device, part of the device that's triggered by heart rate. So about 82% of patients who have seizures have increased heart rate at the beginning of their seizure. It's actually a very rapid rise in heart rate that's different than how your heart increases if you go out for a run or if you're doing something that causes your heart rate to increase. It's a rapid rise in heart rate that the computer sees because it has a little built-in mini EKG machine that monitors the patient's heart rate all day long. And it's always adjusting the heart rate based on what you're doing. So if you do go out for a run, it's going to increase slowly as you go out for your run. If you're sleeping, it's going to go down as you sleep. And what it's going to look for is a change from the baseline. So when your heart rate increases rapidly at the beginning of the seizure, it's going to see that rapid rise in heart rate, and it's going to turn the device on, and it's going to give you a little boost of input that's going to potentially stop or shorten the seizure. So it does that automatically. That's why you heard the mom say that she feels like there's a little safety net built in, because the device is always there watching for a seizure. When it sees a seizure, it will turn on, it will give a stimulation that could potentially stop or shorten the seizure, even if the caregiver is not there with the patient at the time. So this is a nice feature to have built into the device that can potentially give an emergency rescue treatment without having a caregiver nearby. That's called auto stimulation mode. Then we have magnet mode. So the same magnet that you're using to turn the device off, you can also use to activate the device. Excuse me. So this is a magnet that you can carry with you, or you can have it near your child. And if the child has a seizure and you see a seizure starting, or if the person with epilepsy actually feels their seizure coming on, they have a warning sensation, they can use the magnet to swipe over the generator. That will also turn the generator on and deliver this emergency rescue therapy, which can stop or shorten the seizure. Now, the auto stimulation mode tends to be a little faster because that's triggered by the heart rate. Usually when someone has a seizure, the first thing we see is brainwave changes, if we were to have EEG running. Then we see the heart rate go up. Then we get a feeling, if patients have the feeling of a warning, then we see the clinical seizure. So the fastest way to detect it is with brainwaves. We don't have that option with this device. Then the next fastest is heart rate, which is what the AutoStim detects. Then the person feeling a seizure, if that's possible, then actually seeing the clinical seizure. So with the VNS, we have the ability to detect it with heart rate, which is very fast, and with the person seeing a seizure with the magnet. So we have two opportunities to have a rescue or an abortive therapy, which you can do all that before you use your typical rescue med, which most families wait usually around 5 minutes before rescue med. So the hope is with the VNS therapy, either the auto stimulation feature will catch the seizure and abort it, or you can use your magnet to abort it, and you can decrease the amount of rescue medications you have to use, which is a huge win, because what happens when you use a rescue medication? Yes, you may stop the seizure, but often the patient then is sleepy for a period of time, and you may have lost time in that day. So we see, I've had patients in my clinic who start to have the seizure, their body may start to stiffen, and then within a few seconds they just relax. And it's because that auto-stimulation feature caught the seizure, turned on, and aborted it, and the seizure just ends. It's a very cool thing to see right there in front of you. Or the family will get out the magnet and swipe it, and then the seizure will stop after that. So we have both preventative therapy, because the device turns on and off all day long, just like taking your pills every day does, and we have abortive therapy, all built into one device. So that's really good that we have both those features. All right, so we already talked about the magnet. So the magnet serves two functions. You can stop the seizure or potentially shorten the seizure by swiping the magnet. The other thing we do with the magnet is sometimes we get creative. So we have patients who maybe seize in the morning when you wake them up. So sometimes the brain going from sleep to wake or wake to sleep can be a fragile time. So if you have a patient or a child that has seizures first thing, you guys can come up and sit down. You don't have to stand in the back. I don't care. If you want to walk up and sit down, please, doesn't bother me. There's lots of seats. So if patients has a seizure first thing in the morning, what some of our families will do is they'll swipe the magnet a few times before they wake them up. Give a little extra boost of therapy before they wake up and try to prevent those seizures. So you can also use that if you know you're going to be doing something that might be triggering for an individual patient. So you can use the magnet in those instances, or you can use it when the patient's having a seizure. You swipe the magnet for the seizure. Then as we talked about, the magnet can also be used to turn the device off temporarily. So either if your patient or your child is experiencing a side effect, or as I mentioned, we have some patients who sing professionally and they don't like the way the voice changes, they can turn it off for that. Or the athletes if they feel like they're short of breath. So you really have a lot of options with the magnet. All right, so we have some other things we need to discuss about VNS. So as we talked about, VNS is turned on by a magnet. So probably a lot of people who have a family member or a patient with epilepsy may know that you've had an MRI in the past. And an MRI is what? It's a giant magnet. So this could be a problem if you put someone in a giant magnet with the device that's turned on with a magnet. So it's not really a problem. We just have to turn the device off before you get an MRI. So there are some restrictions and some things we need to think about with the VNS, but you can get an MRI with the VNS. So there are some limitations to spine imaging, but most of the devices are manageable to get MRIs, and you can definitely get an MRI of your brain, which is what we're most interested in. So I don't think it's a limitation to get the device, but definitely if you have any other medical issues or any other conditions that you're concerned about, just discuss with your doctor if MRI is going to be limiting. But MRIs of the brain are certainly reasonable and can definitely be done, but the device does need to be turned off. It needs to be turned off by a doctor. You obviously can't take the magnet over it and then go into the MRI scanner. I had a patient try to do that once. Can't go in the MRI scanner with the magnet on your chest, not safe, but it needs to be turned off by your doctor and then turned back on afterwards. Then we have a new feature with the new device that came out a couple years ago, which is a feature I really like. It's called day-night programming. So traditional VNS had one set of scheduling parameters where we turned it on to say, we talked about initially one set of cycling parameters, maybe 30 seconds on, 5 minutes off. You had those settings 24/7. That's the only option you had. And if the patient didn't tolerate the settings you just had to turn them down. You had no other option. Or if somebody had sleep apnea and the VNS was causing the sleep apnea to get worse, you just had to turn the settings down 24/7. That was the only option because that's all we had. Now the device has two options. They call it day-night. I just call it option 1, option 2, because it doesn't have to be day and night. So say somebody has sleep apnea and the VNS is making their sleep apnea worse. You can actually turn the settings lower at night to not impact their sleep apnea, but still have it turned up stronger during the daytime, because we now have option 1, option 2. So we can do a whole lot of things with these options and really have lots of different ways to program the VNS to really get the best response from our patients. So this came out with the updated device a couple years ago and really gives physicians the opportunity to adjust settings so that you can really tailor the settings to the patient's seizures. So you can turn settings up a little higher during the day. You can turn settings down a little lower at night. If they're bothering the patient, you can make the settings tailored to the patient's individual seizure semiologies, to how they're having their seizures, when the seizures are occurring, and it really gives the doctor a lot of flexibility to program the VNS to each individual patient to get the best results. And then we have scheduled programming. So when scheduled programming first came out, scheduled programming allows the VNS to turn itself up automatically. So I program it and it'll go up on its own up to 7 steps when we're first turning the device on. So when we turn the device on, we start at a very low strength, and then we go up in steps every couple of weeks until it gets to a strength where it works. Just like when you start your seizure medicine, you start with 1 pill, and then you go 1 pill twice a day, then you go 2 pills twice a day, and then 3 pills twice a day. You go up slowly so you don't have any side effects. VNS works the same way. You start at a low setting, and then you go up every 2 weeks until you get to a setting where it actually sends that signal to the brain. So normally we'd have patients come back to clinic every 2 weeks to do that, or maybe every month to do that. The faster you get it up to a dose where it works, the faster your child or patient is going to get their seizures controlled. So I never thought this was a big problem until I moved to Los Angeles. And then you ask patients to drive back to your clinic in downtown Los Angeles every 2 weeks, and they're like, yeah, no, sorry. Because, even though they may only live 2 miles away, it's going to be an hour round trip. And then the pandemic hit. And then you ask patients to come out into the world during the pandemic every 2 weeks, and then they're like, yeah, no, sorry, Dr. Holder, not doing that. So this turned out to be something that I didn't think I would ever use. that we used all the time. So it was kind of, I mean, obviously nobody knew the pandemic was coming, and I don't think the company made it thinking that was going to be something that would be maybe as useful as it turned out to be, but now we actually use it on every patient. So every patient we implant gets this automatic programming where we do every 2 weeks, and they can do it at home. So that's been really useful. And then just keep in mind that VNS is not brain surgery. All right, so that you can get more information about VNS from the company and from the website, and we'll stop there.